hear me? Is it?
You don't need a mic.
It's not working.
Okay, so today's lecture is mainly focusing on immunosuppressants. So what you guys need to know about the lecture mainly is the classification of immunosuppressants, the mechanism of actions of each drug class, and the rational use in terms of clinical situation where with the focus only on organ transplantation since this is a renal block. So immunosuppressants, they're used mainly they're a class of drug that are used to suppress the immune responses, and they suppress or reject. They prevent rejection of transplanted organs, and this could be a kidney, liver, heart, and they're known sometimes as anti-rejection drugs. So in the organ transplantation, we know that the body recognizes the self and non-self. So we try to save the organ, the transplanted organ, which is a foreign mass, and this usually triggers the immune system. So the immunosuppressant drugs' role is to suppress the attack on the transplanted organ. However, because there's a weakening of the immune system, this could result in a severe or sometimes high risk of developing infections and emergencies of malignant cell lines or cancer. There's another role that immunosuppressants are used for, which is autoimmune disease. So autoimmune disease is the opposite. Like here, the immune system attacks itself, and as a result, we try to suppress the immune system to reduce the effects on or the impact of the disease on the body. And these could be like thrombocytopenia purpura, hemolytic anemia, lupus, rheumatoid arthritis, psoriasis, methanasia gravis. So how do immunosuppressants work? Going back to basic immunology, what do you know?
There are several drugs and each one has a specific mode of action.
Okay,
So like we have drugs like allopurinol, things like this, which basically are purine synthesis inhibitors, and these things can suppress.
Okay, but going back to the basic of immune, how does the immune system work?
NF-kappa B, downregulation of transcription factors.
Okay, I'm talking more simpler than that. So you know the basics since you're third year student, but what I'm trying to say here with the immune system is divided into innate and adaptive. So the innate is non-specific, fast response. The adaptive is more specific, it's divided into two, the humoral and the cellular. So the B cell are usually they recognize specific antigens by the surface of the antibodies, and they kill like the cells or the foreign substances, whether it be bacteria, fungal, any type of infection. But with the cellular, the T cells, they either divide into CD4 and CD8, and these they circulate in the system until they recognize an antigen, which is later trying to find whether it's a self or non-self, and based on that they trigger the immune system. So the adaptive is more specific and slower, and usually activated by the innate and non-specific immune system. So how does this work is when the T lymphocytes circulating in the system, the circulation, and it's activated, recognized dendritic cells, which is it's an antigen presenting cell. So it binds to the MHC, yeah, right?
Yeah.
So this differentiates between the self and non-self, and this later activates the T cell, which leads to activation, replication, differentiation, and the differentiation leads to a release of effector cells known as proteins or cytokines. These cytokines, proteins, they activate later the immune system, which is the B cell, T killer cells, and phagocytes to augment and make the immune system work better, more specific to survive or to help improve the inflammatory response. Okay, so how does that work? summarized here. When the antigen-presenting cells binds to the T cell through the MHC receptor, it could be CD4, CD8, it needs a co-stimulation with the CD28, so the binding of CD8, CD86. So the co-stimulation leads to the full activation of the T cell. This leads to calcium-mediated increased cellular signaling. So the cascade of reaction that occurs, it leads to the increasing intracellular calcium that later increase the calcineurin. So the calcineurin activates the NFAT, which is later translated into the cell, activates the cell replication and release of interleukins, cytokines, also interleukin 2. The interleukins then released outside of the cell, activates its receptor, IL-2 receptor, and then activates the mTOR, which is the mammalian rapamycin. And this leads to activation of the replication of the T lymphocytes, and later leads to production and proliferation of the adaptive immune cells with the T cells, macrophages, and natural killer cells. So basically, the immunosuppressant drugs, they work by inhibiting one of these pathways. So in this case, for example, the calcineurin inhibitors inhibit this pathway, so prevents the conversion of NFAT, and later leads to inhibition of IL-2 later. Something else that could be inhibiting, you can inhibit the mTOR here, or we can design antibodies that inhibits the IL-2, so preventing the IL-2 cytokines from binding to its receptor. So this is mainly how immunosuppressant drugs work in general. But we have a few types of them. So we have the glucocorticoids, we have the calcineurin inhibitors, we have the purine that you mentioned, like azathioprine, mTOR inhibitors. We have also the antibodies, so we can design antibodies that can be antigen specific. With the antibodies, we have two types of antibodies. We have depleting and non-depleting antibodies. The depleting means they kill the cells, so they kill the B cells, T cells, lymphocytes, and prevent the proliferation. The non-depleting is they mainly mediating the cytokines, so they upregulate the mechanism, so they could inhibit the IL-2 receptor, for example, in this case. There are other types of groups of immunosuppressants, but I just kept the ones that only related to organ transplant. So we can divide them into two groups. They could be either the ones that we use for induction and rejection therapy, and the other ones that we use for maintenance immunosuppressants. So for the induction therapy, we usually use them at the start of the transplant. So they could be monoclonal antibodies, polyclonal, glucocorticoids, or the IL-2 receptors inhibitors. The maintenance one, these are the ones that are usually given long term, like glucocorticoids, anti-proliferative drugs, the purine inhibitors, mTOR inhibitors, and calcineurin. So these are used more for long term use. So the therapy itself will start with induction therapy first, higher immunosuppressive loads. So usually it gets high doses of the drugs are given at the early stages of the transplant or at the start of the transplant. So depleting, non-depleting antibodies. Then we have the maintenance phase, which is a combination of corticosteroids, calcineurin inhibitors, and anti-proliferative agents that are usually given. In case of any rejection that occurred after transplantation, we can give, we try to save the graft as much as we can, and this prompts usually recognition of aggressive treatment, so to prolong the survival of the grafts. And in this, we usually use a combination of bacillizumab, which is an IL-2 inhibitor, it's an antibody, or with the calcineurin inhibitors and glucocorticosteroid or corticosteroids. So for the induction and rejection therapy drugs, we use powerful anti-rejection drugs used at the time of transplant, depleting and non-depleting. as I mentioned, and as I said, they destroy the T cells, B cells both together. So the first example that I mentioned for the induction therapy, I'll give an example of polyclonal antibody, and which is anti-thiamide globulins, and the other one will be the rituximab. So the polyclonal antibodies is less specific, but it's relatively inexpensive to use, and usually it's used in induction therapy in kidney transplant and rejection. An example is usually anti-thiamide globulins. They're produced by gamma globulin extracted from rats and horses after immunization with human thiamide. But the rabbit preparation is usually better than the horse because it has high potency and low toxicity. So the anti-thiamide, as I mentioned, they are depleting antibodies. So they work by depleting the circulating T cells and activation of the apoptosis T cells. There are three different pathways by which they actually work. So this could be either apoptosis by activation of the induced cell death. So this is more like a programmed cell death where they bind to a death cell receptors like FASL and later into the lysis of the cell. The other one is antibody-mediated cell cytotoxicity, and this is usually carried out by something like activated natural killer cells that binds to the cell and later also the same endpoint of killing the cell. More complicated one, which is the complement-dependent cytotoxicity, which is usually mediated by an effector cell, which could be an IgG or IgM. That binds to a receptor and activates a complement activation, so binding to another surface which activates the membrane attack complex and later leads to the lysis of the cell. So you don't need to go into the different mechanism of actions, but you need to know the different types of mechanism by which those drugs deplete the circulating T cells. So the anti-thiamide globulins, they adverse effects usually could be cytokine release syndrome, so fever, chills, hypotension, leukopenia, and thrombocytopenia, since they're depleting, since they have like an inhibition of the blood cells. And to prevent that, we usually give paracetamol, corticosteroids, or antihistamines to prevent this. So the first one is an example of polyclonal antibody. So another example is the monoclonal antibody, which is also used, but these tend to be more specific antibodies that are homogeneous and very expensive to use. So that's why we try to use them only in the first during the transplantation period. So there are different types of monoclonal antibodies. There could be a mouse one, which is the suffix is usually MOMAP, or chimer, which is XMAP, like rituximab. We also have the humanized one, which is the ZUMAP, and the human, which is OMAP. So the different types of them that are actually used and in the market, and they, as I said, they are more expensive to use. So rituximab is a chimeric monoclonal antibody that specifically binds to CD20 in pre-B cells, mature B cells, and memory B cells. So intravenous administration of rituximab leads to rapid and sustained depletion of B cells. So it's a depleting antibody. Induce the killing of the cell by the same principles as the polyclonal antibodies. So complement pathway, directly antibody-dependent cell-mediated cytotoxicity or induction of apoptosis. But usually the recovery of B cells occurs between 9 to 12 months later. So at the same, as I mentioned, they bind at the cell surface of CD20 and then activate cell death. The adverse effect is similar. It could be infusion-related effectors, chills, fever, hypersensitivity, but there's a red box that comes with using rituximab, which is the reactivation of hepatitis or B infection. So here's a list of other types of antibodies, but this is for common knowledge if you want, but the most important one I would focus on, because it's a different example, is the basiliximab, which I already talked about. So it binds to the CD25 and inhibits the T cell proliferation. So it leads to induction therapy, it uses induction therapy and treatment of rejection. And by far it's the most well tolerated and immunosuppressants used currently. The second ones that are used are the glucocorticoids. So these are the mainstay and the most common immunosuppressive regimens that are actually used at the moment, and they've been used for a long time. So they're used in induction as well as maintenance phases of organ transplant. They're given intravenously at high doses for induction therapy, but because they are lymphotoxic, so they kill the T cells and B cells at high doses. When we taper the dose for maintenance, we use the low doses, so they have more anti-inflammatory and immunosuppressive activities because they limit the cytokines release. An example is prednisone and prednisolone. So the glucocorticoids, they bind to the receptor at the cell surface, and they translocate into the cell and inhibits the NF-kappa B, which later leads to different types of cascade reaction that inhibits. One of them is inhibiting interleukin 2, which is important in T cell proliferation. So they have, as I mentioned, a lot of mechanism of action, but they inhibit NF-kappa B translocation. They suppress cytokines release, production, but IL-2 is the main one I would focus on. Tumor necrosis factor alpha, apoptosis of lymphocytes, so reduction of B and T lymphocytes, inhibition of antigen processing and displaying, suppression of cell adhesion, inhibition of leukocytes, that later leads to inhibition of leukocytes, inhibition of inflammatory mediators production, histamines, bradykinin, prostaglandins. So their mechanism of action is quite broad and depending on the dose, and hence is their side effects. So the side effects usually it depends on how long they've been used for. So weight gain, osteoporosis, glucose intolerance, something that we see with long-term use, hypertension, high cholesterol, mood swings with the short-term use, poor wound healing, and also mineralocorticoid effects. Rituximab. Why?
Because rituximab is not reactivated by this.
Okay. Yeah, so it's mainly rituximab. So moving to the maintenance immunosuppressants drug, as I mentioned earlier, with the first one is the calcineurin inhibitor. So they inhibit the production of IL-2, which is immune response inhibition, that later leads to decrease of graft rejection. Main example is tacrolimus and cyclosporine. IL-2 is the growth factor that stimulates the antigen-primed T cell, leading to increase in IL-2, INF, gamma, and TNF alpha. So similar to this, cyclosporine comes here, enters the cell. So they're also known as small molecule inhibitors. So they bind to cyclophilin. They inhibit calcineurin. So this later inhibits the cascade signaling, which prevents the activation. So both, actually, I should have mentioned that both tacrolimus and cyclosporine, they have the same mechanism of action. But the only difference here is that cyclosporine binds to cyclophilin, whereas the tacrolimus binds to FK proteins. But at the end they have this. They inhibit calcineurin, which prevents the activation of N fats. So calcineurin mediated, this is just what I mentioned, so inhibits the NFAT so they cannot enter the nucleus and hence prevents the production of interleukins and synthesis of cytokines. But the main uses are the main maintenance in immunosuppressants. CNS alone is tolerated, but they can be used with a combination of other therapies, so anti-proliferative agents and mTOR inhibitor. The main adverse effects with it is nephrotoxicity, and this usually occurs due to alteration in production of renal prostaglandins, decreased renal blood flow, or increased renal vascular maintenance at the glomerular level. So due to that, it leads to nephrotoxicity, but also has another side effect, which is gum hyperplasia and hirsutism. Both cyclosporin and tacrolimus, they have adverse effects, but tacrolimus doesn't cause gum hypertrophy and doesn't cause hyperautism. So the second one is the second class is the mTOR inhibitors. The target size of the mammalian target of the rapamycin, which is a key regulatory kinase in cell division. Sirolimus is an example of that. And the mTOR binds to the FK binding proteins that later inhibits mTOR. So inhibition of mTOR leads to prevents DNA cell cycle progression and prevents the replication of the cell. So later prevents the proliferation of the T lymphocytes. Is used in maintenance therapy, but it's combined with the calcineurins and glucocorticoids. This allows lower doses at those medications to be used to lower their toxicity. So lower doses are used to prevent toxicity, but what you need to understand is when we use CNI with the mTOR, we can't use cyclosporin because this potentiates the nephrotoxicity, but we can't combine tacrolimus and sirolimus together with corticosteroid, but not with cyclosporin. Okay, so potentiate the cyclosporin and nephrotoxicity. It also can cause this lipidemia, impaired of wound healing in diabetic and obese patients, and also patients who are receiving glucocorticoids. It can also cause leukopenia and thrombocytopenia. Okay, and with the anti-proliferative drugs, these are the purine inhibitors, and they block the lymphocytes proliferation by inhibiting nucleic acid proliferation. An example of that is azathioprine and mycophenolate mofetil. So these azathioprine is the oldest immunosuppressant to be used, and it's a precursor of 6-mercaptopurine, and anti-metabolites that block purine synthesis. Sorry guys, can I ask you to go out, please? Sorry. So it's a precursor of the 6-mercaptopurine and anti-metabolites that block the purine synthesis and inhibits the proliferation of lymphocytes. Does not inhibit, but okay, keep that in mind. The difference between azathioprine and mycophenolate mofetil is that azathioprine does inhibit interleukin, whereas the more recent one that is used inhibits interleukin, and is an inhibitor of the inosine monophosphate dehydrogenase. So this inhibits it's an enzyme that required for the guanine synthesis, and it's required in DNA synthesis. So I'll explain this here. So the drug works in this pathway. We have cell division that occurs inside the cell. So MF, and azathioprine purine inhibits the guanine, inhibits the enzyme. No, okay. So they're both purine inhibitors, so they inhibit the purine synthesis and later inhibits DNA replication. But the mechanism of action is different. One inhibits the mercaptopurine, and the other one inhibits the inosine monophosphate dehydrogenase, which is an enzyme required for the protection of guanine synthesis. And guanine synthesis is required for DNA synthesis. Thank you. So they used in mainstay, as I said, and in combination with calcineurin inhibitors and glucocorticoids. The adverse effects of other thiopurine is their bone marrow suppression, liver dysfunction, and skin cancers. Mycophenolate mofetil, they cause GI toxicity, but we use sometimes the enteric-coated mycophenolate sodium, which is to prevent this from happening. It can cause diarrhea, neutropenia, and anemia. Viral infection can also occur. But all these side effects occurs with the long-term use of immunosuppressants. I didn't want to go to the drug interaction because it's a very long list, and I don't expect you to know all of it. But what you need to focus on here is the glucocorticoids. The main ones is NSAIDs, so we try not to use it with NSAIDs. Calcineurin inhibitors, calcium channel blockers, antibiotics, grapefruit juice, fruitinolide, which is antiviral drugs. mTOR, the main one I would focus on is cyclosporin. Other thiopurine, we won't use it with other purine inhibitors like the one used for gout, allopurinol. Mycophenolate, we don't use it with cyclosporin because that can increase the side effects of nephrotoxicity. Okay, do you want to guys read the question?
Read the question.
68-year-old woman comes to the physician for a follow-up examination. 3 months ago, she underwent heart transplantation for restrictive cardiomyopathy and was started on transplant rejection prophylaxis. Her pulse is 76 per minute and blood pressure was 148/82. Physical examination shows enlargement of the gum tissues. There is well-healed scar on her chest. Serum studies show hyperlipidemia. The physician recommends removing a drug that decreases T-cell activation by inhibiting the transcription of interleukin-2 from the patient's treatment regime and replacing it with a different medication. Which one of the following immunosuppressants is most likely to cause the adverse effects seen in this patient? Calcineurin.
Cyclosporin.
So if you say one, then you need to tell me why, not just throw an answer.
Cyclosporin causes gum hypertrophy and hyperlipidemia.
So what, if you look at the question, can you tell me how did you come to the answer? Like, what's the clues that you see in the questions that give you the answer?
Gum tissues,
Interleukin-2,
hyperlipidemia.
So why not tacrolimus?
Because it doesn't cause gum hypertrophy or hyperlipidemia compared to cyclosporin.
They both affect T-cell, just the side effects are different.
Yeah. So the only thing that tacrolimus doesn't do is that it doesn't cause gum. It doesn't cause gum hyperplasia. So in summary, in general, immunosuppressants are used in preventing graft rejection, organ transplantation. So immunosuppressant drugs, they have in autoimmune we use them to reduce the symptoms of the disease, and there's different types of mechanism of actions, and which can be increased or reduced by other drug interaction by other drugs. But efficacy and the dose that we use is usually tailored to the patients and patient's history. The general suppression of the immune system increases the secondary causes of like infections and cancer. The risk of adverse effects is increased with lifelong treatment with immunosuppressants. know this lecture went really bad because I wasn't prepared for it, and I'm really sorry. But what I want you to focus on, just you need to know about the mechanism of actions of the drug. So the questions that comes in the exam will be similar. And what you need to know is you need to know the mechanism of action. So as I think some of you know here, so if you guys don't know, just please email me. And I'm really sorry about today's lecture. I'm really sorry. But focus on the mechanism of actions and the adverse effects of the drug. If you have any questions, you think the lecture went really bad, just let me know if there's anything I can help with. Any more questions?
Doctor, there is a table with a lot of drugs. Do you need to know all of them?
Which
So you put three diagrams, and one with a lot of drugs, one with. It's at the beginning. It's a tree diagram. Yeah, this slide.
Okay, this one? This one?
No, this not this one. The one above. Slide 8 was it? Yeah, these ones.
No. Here, what I was trying to do is I'm just show you the whole classes of the immunosuppressants. But it's exactly the same thing. So what I showed here is exactly here. But the difference is I divided them into the drugs that I use for induction and therapy and drugs I use for maintenance.
Should we memorize all these drugs?
The different classes, yes.
Alright.
So you need to, these are not different drugs, so you have different types of drug classes which you need to know about.